We can have the introductory slides. Recording has been started. We start. Yeah, recording is there. So we all set now. Welcome all of you to this 248th edition of Thursday Musings. Today we have an outside expert, so to say, because he will be teaching us about the occupational therapy, how to use it in autism and its spectrum. So the session is being recorded. This recording will be put on the YouTube channel for later viewing. The questions are invited in the chat box. So all the audience are requested to post their question in the chat box. This will be taken up with the presenter and the chairpersons. Yes, and everyone will be on the mute mode. We will not allow unmute unless until we are able to verify the person. So next slide, please. Handing over the session to the chairman of this program, Professor Dr. Sofan Pati, sir. Over to you, sir. Please take over.
Thank you, Dr. Elim. Welcome to the 250th minus 2 sessions of Thursday Musings. Glad that you are all here. Next slide, please. I have the pleasure to introduce and reiterate the contribution of the 5 moderators, Dr. Amrit Patudosi, Dr. Elim Siddiqui, Dr. Vishal Shabra, and Dr. Shobit Garg. All of them are brilliant contributors to Thursday Musings. Change slides, please. Yes. And I have the pleasure to introduce our chairperson, Dr. Bikram Kumar Datta. He is MD Psychiatry and DM in Child and Adolescent Psychiatry. Professor in Armed Force Medical Services, Head of the Department of Psychiatry in Guwahati. He jointly shared Colonel Kripal Singh Award for Best Paper in Military Psychiatry in 2024. Fellow of IPS Indian Association of Child and Adolescent Mental Health. Recognized undergraduate and PG teacher, national and international publications 11. Areas of interest, child and adolescent anxiety, depression, ADHD and behavioral interventions. Welcome, Dr. Datta. Next, please. Dr. Manjari Deshpande from Mumbai. I've heard she will be joining soon, but in absence, I'm introducing her. She'll be there with life in the museums when she comes. Indra's Child Guidance Clinic in ICGC. 5 centers of ICGC in India, multidisciplinary center consisting of all therapies under one roof, practicing exclusively child and adolescent psychiatry for the last 10 years, DNB psychiatry, fellowship in child and adolescent psychiatry. With this, I welcome Dr. Manjari Deshpande in absence. And I hand over the meeting to Dr. Datta. Kindly introduce Dr. Baga and introduce the topic. And if Dr. Manjari Deshpande arrives in the meantime, we'll ask her to contribute to introduce the topic. Over to the chairpersons. Please take over. Dr. Datta, please.
Thank you so much, sir. Thank you, Tofan sir. Thank you, Vishal sir, Alim sir, Amrit sir, and the entire Thursday Musings team. It was about 3 months back since I last chaired a session. I have always been an avid watcher. Maybe I have watched more than 200 out of the episodes since it started soon after COVID.
Thanks a lot.
And it's a really honor. And once again, I'm grateful to the entire team. So since Dr. Manjiri is currently not there, I would like to introduce both the topic and the speaker for today evening. So about the occupational therapy and autism. We all know the prevalence of autism has been increasing, and not only child psychiatrists, the psychiatrists in general in their practice, the pediatricians and the developing pediatricians in their practice have been seeing an ever increasing clientele of patients in the spectrum. Maybe not pure autism, but since the DSM-5 and ICD-10 has enlarged the spectrum, we are seeing too many children who are falling in the spectrum. Now, what do the usually the pediatricians do. Usually they're the first contact. So what they do usually is to do the investigations, maybe check for some genetic syndromes, and then through early intervention clinics, they hand over to the speech therapist or the occupational therapist. So we all know that sensory processing difficulties are one of the core features. It's present in about two-thirds of children with autism. And these children, they could be either hypo or hypersensitive to various stimuli in the environment. Occupational therapy forms a large part of getting these children overcome their sensory processing difficulties. And this uh, process and this process uh, involves not only engaging with the child, the clientele, but engaging with the entire family, and to generate some purposeful or meaningful activities in a playful way, and which the occupational therapist does it in a much organized and comprehensive way. Why we should know about this? As primarily we are psychiatrists, because when the patient comes to us, we have to we see them for the more frequent number of time. So in order to enable the therapy process to get on, in order to enable the parents to get a mastery over what is being told in the therapy, whether they're practicing in day-to-day practice, what difficulties, and to enable a comprehensive care in order to improve the sensory processing as well as the wellness quotient in the child as well as the family. So in this context, I am very fortunate to welcome Dr. Roshan Singh Bagga. He is an eminent occupational therapist practicing in Delhi. He has this Center Therapy for Ability, and he has more than 17 years of experience working with the special need kids and parents. He is an expert in pediatric occupational therapy and interventions. He does treatment on combining neurodevelopmental treatment and sensory integration principles in children. He has developed interesting intervention program in areas such as sensory integration, self-regulation of alertness, and attention. And also he works extensively on fine motor skill, cross motor skill, handwriting, play, and interaction. I think we'll all benefit from today's lecture. We welcome and I hand over to Dr. Bagga for his
Dr.
lecture.
Manjari is also there, so
Ah,
he can also chip in. Manjari, ma'am.
Yeah, thank
Yes,
you.
ma'am.
Yeah. Yeah, thank you. I think it's a very important and interesting topic. So, as we deal in child psychiatry, I think all of us will agree that autism is only increasing, and there is no way that we cannot understand the nuances of autism or the role of occupational therapy. I think one very important thing is most parents who come to us, and when we diagnose with autism and we tell them that, we have to start occupational therapy, most of them will say, no, pehle aap speech therapy shuru kar dijiye, because for them, the child to speak, I think that is most important. But they don't understand that first, if we don't deal with the motor skills, the social skills, the nuances of occupational therapy, even speech therapy will not benefit. And I personally have seen a lot of great results when occupational therapy has been done in a very meaningful way, and it definitely benefits, also helps in inclusion. So the children of with autism go to mainstream schooling, and I think that adequate exposure to occupational therapy is probably the reason that they are able to regulate themselves better and be able to go to mainstream schooling, which should be our aim. So yeah, looking forward to the interesting talk. Thank you, Dr. Maga. Thank you for having me.
thank you, ma'am. I think I can start the screen sharing.
Yes, please.
Yes.
Yeah. Is it visible?
Yes, sir.
Thank you. First of all, thank you everyone. It's my pleasure to speak in front of such a renowned doctors and the professionals who are actually working in the field of autism so well. And and it's a great honor for me being an occupational therapist. having that respect that you have just called me to explain you all what basically occupational therapy is and what is the exact thing we are looking in an occupational therapy while he is treating an autistic kid. I was having a discussion with Dr. Garg and he told me कि आप अपना topic खुद select करो. And so obviously primary जो mind में सबके आता है वो आता है कि अगर occupational therapist है तो it should be sensory topic because it's the primary thing which is having autism में सबसे ज़्यादा difficulty होती है. But now, you know what? I have selected a topic like a comprehensive role. There are lots of doctors who are actually trying to set up a multidisciplinary setup in this setup and वो मुझे ये कहते हैं सर हमें ना ये बताइए कि एक अच्छा ऑक्यूपेशनल थेरेपिस्ट होता कैसा है. मेरे पास इतने बायोडाटास आते हैं बट मुझे समझ नहीं आ रहा कि कौन सा अच्छा ऑक्यूपेशनल थेरेपिस्ट और एक्चुअली ऑक्यूपेशनल थेरेपी में क्या क्या चीजें हैं जो एज अ अगर मैं किसी ऑक्यूपेशनल थेरेपिस्ट को हायर करूं जो मुझे पता होनी चाहिए कि नहीं ये चीजें हैं जो ये सब ऑक्यूपेशनल थेरेपी में डील होता है.
Dr. Bhagat, there are people here who don't understand Hindi from
Okay,
other
I'm
parts.
sorry. Then I'll just
Yeah,
speak in
I just wanted to inform.
English. So that's
Okay,
the
cool.
reason I have just selected a topic about the comprehensive role of an occupational therapist. So absolutely, as ma'am said, and as I was also introduced by a doctor, that in autism, the kids have a lot of sensory issues, and that's because of that we have to refer the kids to the occupational therapy. Well, that is one of the things, obviously, but that doesn't mean if there is a high functioning kid who has a very less sensory issues will not be referred to an occupational therapist. He should also be referred to an occupational therapist. So this thing, definitely the sensory is the primary aspect we are looking for it. But yes, there are lots of other things which we have to look for. So that is the topic, the comprehensive role of an occupational therapy in autism. So now, before I start, I really want to explain the occupational therapy. Now, you know what? Occupation means if a person is diverted from his profession by anyhow, maybe he had an accident, he had some deformities, or whatever the reason is. And it's my duty as an occupational therapist to bring him back to his occupation. So supposedly, if there is any person who met an accident and he is now diplegic or hemiplegic and he used to go to his an office, so I have to modify the environment accordingly so that he should come back to his occupation. So now, when we talk about a pediatric occupation, the primary thing is that the child who are diverted from their occupation, it's one of my role is that to bring them back to their profession, to bring them back to their occupation. So now when we talk about occupational therapy with autism, so there are lots of things as an occupational therapist I look for. And you know what, when a child is coming to me, and supposedly there are some times when I'm assessing a child of 1 year of an age, and there is a time when I am assessing an autistic child who is of 8 years of an age. So, you know what, when we are talking about a child who is at the age of 8 or 9, so I can't have that perception, okay, now he has a sensory issues, I have to deal with that sensory issues. No. At that time, my perception of occupational therapy is entirely different. If I'm dealing with a child who is 2 years, 3 years, 4, or maybe 5 years, my perception of working with that child will be entirely different. So according to the sequence, I have just tried to make a sequence. And you know what? The sequence has been made with a child of an age of 8 months to a year, till when we are going to the at the down where the supporting social interaction and developing self-care. Here I am talking about a child who is actually at the age of 7 to 8 or maybe 9. So I'm just trying to cover all the things. So you know what I'm going to do is I just want to visualize. I just want all of you to visualize a child, and it happens a lot. Like there are lots of children who used to come to me at the age of 2. Now they are at the age of 8, and they're still coming to me for an occupational therapy. And then you know what? Suddenly, if there is some new parents who have come to me, they are shocked. Sir, मेरे बच्चे को इतने साल आना पड़ेगा. They also have to come for the occupational therapy for 10 years. Oh my God. So that's one of the things I want to tell. Yes, maybe there is a probability your child has to come for the OT, maybe if he's at the age of 10, but the goals will be entirely different. It will not be the same like the child was at the age of 2. So What we are going to do now is, so we are going to have one case who came to me at the age of maybe 2 or 2.5, and he was with me till the age of 8. So what were the things I did with that kid? And why I took such a big span of 6 to 7 years when I actually graduated that kid from my center, and now he is independent and now he can go. So that is one of the things. Now, let's begin. A child who has entered my clinic at the age of 2. The primary thing, so absolutely, सबसे पहले हमारे mind में आएगा, we will be thinking, okay, if the child is 2 years of age, that means the therapist has to deal with the sensory issues because there will be a lot of sensory issues. No. You know what? I will always start my session with a play. You know, one of the reasons I have been dealing with lot of kids, and one of the common problem which I have seen in the kid who are at the age of 2 or maybe 3 is an anxiety. You know, I am a very firm believer. If I am able to reduce the anxiety in a month or maybe sometimes in 2 months, you know, my journey, my further journey is going to be very, very easy. So the primary thing is not occupational therapy. I'm not going to start with an occupational therapy. I'm not going to try to go for any sort of a sensory assessments with the kid. I will just play and just play. Now when we talk about the play, the most important question comes is, should the parent be inside the room or they should be outside the room? Because sometimes the kids are very defensive and they don't leave their parents, and then the therapist says ki, man, you have to go out because your child is just with you and he's not mingling up with me, so what should I do? You have to go. If you're going to ask me, it's a absolutely wrong perception, because if it's a normal kid also who is at the age of 2 3, I know we all know that parent separation anxiety is one of the very common thing. So if the child who has come to me, I'm not going to send the parents out till the time I have that trust building where the child is coming to me, he's saying hi to me, and he came and hugged to me. That is a primary thing an occupational therapist should always start with. So when we talk about this thing, then the question comes how to connect with a child. When and what are the strategies an occupational therapist should use where there is a day when the child is coming and hugging the therapist. So that play, I'm just going to discuss a little bit of a play now. And you know what? There are lots of doctors who want to set up their OT room. You know what? I just want to give one of the things to you. Keep one empty room, maybe a very small room, but always try to keep a one small empty room in your center, which should be non-stimulatory. Why I'm saying non-stimulatory is because of two reasons. If you're going to keep lot of toys, you know what? When we Google the occupational therapy room, you will see such a fancy, colorful room. Oh my God, there are so much of lights, colorful mats. There are lots of swings hanging. There are lots of sensory toys. Trust me, this I'm not a big admirer. I just want to keep my room as simple as possible. Maybe I can use just one or two types of colors, very, very, very soothing colors for them. And you know what? I just want to keep all my toys, which should not be in the reach of the kid. And if we want something, obviously the kids are going to get attracted towards the thing. Maybe they might need something from that room to stim. Maybe they need something to explore, or maybe they know that this is a thing with which I can really stimulate myself. So you know what, if you're going to have, now imagine you have lots of toys lying on the floor, then why will the child come and connect with you? He will never come because he had the thing which he wants. He is not bothered in connecting with you. So that's one of the reasons where I always say to the occupational therapist that always have one empty room. Keep all the toys. I'm not saying don't keep the toys, but don't keep it in the reach of the kid. Let the kid ask for it. And you know what? How I start is I always sit very far from the kids. I tell parents to make your kid sit in your lap. Let me be very far. I'm not going to touch your child. At least I'm not going to touch it for 3 to 4 sessions. I'm going to be very far, and I'm just like a joker. who is just going to play in front of, and you are just looking at him. So maybe I am doing some imitations, or maybe I am doing some facial expressions, or maybe I'm doing some drum beats or whatever. I'll just try to have that attraction, like the child look at me. If the child starts looking at me, that's the point where it's very clear now the child is relaxed. So this is the most important thing. Forget about the all sensory issues, forget about the occupational therapy. Play is the primary thing which I really want in every child. You know what? And there is a time when, and I always try the parents to get included with me. So if I'm doing the imitations, let the parent do the imitation with me. And you know what happens? Then the child look towards the parent. What is my mama doing? And he sees, okay, mama is also doing what the therapist is doing, or maybe what the sir is doing. And there will be a time he will just try to imitate, or maybe just try to, he will enjoy that thing, and he will just try to do something which will give me an interaction, or that can give me just an idea. Fine, now the child is comfortable in this room, now he is accepting me. You know what, this can take few days, this can take a week, this can even take a month. So this, let it be. So I'm always, whenever I take a new case now, so I always try to have in the morning. I don't take any new case in the evening because I'm already very tired. So I don't have that fresh mind where I can play with the kids. So anyways, so that is one of the things. So this is how we start playing with the kids. Now we have lots of assessment scales of sensory assessment, which we are going to discuss later on. But that's the point where the clinical observation also starts. So supposedly, imagine if I have kept some sensory toy and it's in my hand, and the child badly needs it because he is a very stimmy kid. So he will just come to me. Now there are lots of things. While he's coming to me, I have put a textured mat in front. So if he's avoiding to come to me with that textured mat, that will give me an idea. Okay, fine. This child is having a tactile sensitivity. And supposedly, if I have a swing, or maybe I have a ball where he wants to come and he wants to bounce, that will give me an idea. Okay, fine. If the child is just bouncing so much in the ball, that means his vestibular system is very hypersensitive. We have to relax it. Or if supposedly the child seen a ball or maybe a swing, he just went and hugged his mother, and he was not even bothered to look towards the swing or maybe towards the ball, that will give me an idea. Fine, this vestibular system is not, it's very sensitive, so we cannot give him the movements initially. So that's where the clinical observation starts. So with the play I start with the clinical observation. So the most important thing with the play is that parent separation anxiety is the most common thing which every occupational therapist should avoid, at least for 5 to 7 sessions. Don't stimulate the room too much. Have a very basic sensory toys. You know what? We know that kids are fascinated towards the car. They are obsessed with the car. And I see lots of car toys. Yes, we can use it as a reinforcer, but that can also be a distractor for the kid. So as a therapist, I should be experienced enough to see when to use which toy. So that is the important thing. And trust me, I have a very basic toys. I have a bubbles. I have one musical toy. I have lot of pastas and cereals where the child can actually explore. That is a very important thing. I have a few cause and effect toys. Maybe if you're hammering, then there is something which is popping up. So keep the very, very simple toys initially, and that's how we start with the play. Now, remember, I'm talking about a child who is at the age of 2. Now he is coming to me. Now it's been 3 months. He is very comfortable. Now, in fact, there may be a reason. Now we can say, parents, now, man, you can move out. Let us work. You can watch the session from the camera. The screen is outside, so you can go. At that time, I can assure you the anxiety is not there. The child is absolutely comfortable. And that's where I'm going to start with the sensory treatment. Now, so the second thing is about the assessment. One, I've already told you, the most powerful toy. Trust me, I don't believe much on the profiles. I don't believe much on the parent interviews. The reason is, if the child is very small, you will not get 100% accurate answer from the parents, because there are a lot of parents who are in a denial position. So let me give you an example. So if supposedly I'll ask, did your child crawled? They will say, yes, sir, he crawled. Yes, he crawled. But when I observed him clinically, I saw the pelvic control is not so good. He's having a flat feet. He's having a very weak truncal control. His shoulder girdles are not strong. And after 10 or 12 session, if I'm going to ask the same question with a reasoning, ma'am, you sure that your child crawled? Because I can see him, his neck strength is not good, his vision is not stable. And you know what? After 10 or 15 session, what the answer I get? I get, yes, sir, he crawled, but it was not the right way he crawled. It was just like a boot scoot he did, or he was just dragging his leg, one leg, and he was not pushing his other leg. So sometimes, and especially this happens whenever I sit for the occupational therapy assessment, I don't trust the parents too much because I know they are in a little bit of a denial thing. And if we are discussing so much of an issues, they themselves can become anxious. Oh my God, my child has so much of issues. So clinical observation is a primary thing. Maybe after 4 or 5 sessions, I can give them a sensory profile. See, ma'am, this is a profile. It contains 100 questions with each sensory system. If you feel your child is not very comfortable with certain sensory explorations, then do let me know about it. So that's the second way where I give the profile to the parent, and it will be, I work in a different way. So after 10 sessions, I again sit with the parent and then I start asking them, what is your priority? So again, I am talking about a child who is 2 years of an age, but I'm not talking about a child who is 8 years of an age, because there the assessment will be entirely different. So here is the case. He came to me at the age of 2.5. I assessed him sensorially. I started a treatment. Now he is 2.5. So maybe he's 2.5 or maybe 3 years. So I have given that 6 months to that kid. Okay. Now, maybe the parents can say, okay, sir, there is not much improvement in the sensory sensitivities, but he is giving me an eye contact. He is giving me a name response. Whenever I'm calling him for the play, he is coming to me. That is the most important thing. See, occupational therapy is a treatment which will go for a very long period of time, but the play has certain age. So my primary goal is always been, let the child play first. So when the child is sitting with the parents, when the parents come to me, sir, now he is sitting, now he's giving me the eye contact. When I play the music, he just comes and says, okay, let's play passing the parcel game. That's where I start with the sensory activities. That's where I start with the sensory sensitivity things. Okay, so now when we talk about the sensory integration therapy, there are primary things. Obviously, we know that there are three primary systems which we have to take care. One is a tactile system. Obviously, ma'am has already told that we have two types of sensitivities. One is hypo, one is hyper. I'm not going to discuss that in detail. But tactile, if the child is not settled in a tactile, I can tell you, no matter how much you work on the proprioception, no matter how much you work on the vestibular system, your child will never be settled child. One of the reasons is because if I am avoiding to touch something, or if supposedly I'm a very big seeker where I don't want to leave anything, in that case, if I am not leaving my hand, if I'm not engaging my hand, how will my brain develop? Because I have to explode through my fingers. So no matter how much you give the vestibular inputs, no matter how much you put that weight curves and you can make him walk on the ramps or something like that, but till the time my fingers are free, they are accepting the textures, you will never feel a development in the kid. So my primary goal is to make a child very comfortable with the tactile inputs. And the second input is the vestibular. Obviously, we know that the kids actually need lot of spatial orientations. They don't have awareness of their body, they don't have awareness of the environment, they don't have any awareness if they have any pain or the interoceptions are not developed properly. The vestibular part is the second part which actually plays a very, very important role. Actually, I should say the vestibular plus proprioceptive, they both have to go together. Fine. So now I'll start with the vestibular part. So suppose that the child has come to me for the sensory integration therapy, or the doctor has referred me. Okay, you have to go to the therapist and just start with the sensory therapy. I will always start with the tactile. Then I will go for the vestibular and proprioceptive together. So the goals of the sensory integration therapy is to decrease the sensory sensitivities. Again, I'll just discuss three primary inputs: the senses, tactile, vestibular, as well as my proprioceptive. So if the child has decreased that sensory sensitivities, or he is now comfortable with those sensory inputs coming to his body, that is my primary goal. The second is there is no use of any sensory input till the time the child is aware about his body. Let me give you an example. You know what? I have seen lots of therapists giving a plan to the parents. Your child is hyper, give him the bouncing on the ball because he needs that vestibular input. My approach is entirely different. What I tell parents is, see, ma'am, how we are going to start is stop the vestibular input. Just stop that bumpy things, maybe your sofas or maybe your bed mattresses where he is jumping. Just try to stop that jumping thing. And then don't give him any trampolines, don't give him any gym ball. Stop that vestibular input and let's see whether there is a decrease in his hyperactivity or not. And you know what? Out of 10, 6 cases there are where the parents come and say, sir, till I have removed the ball from my room, I have removed the trampoline, I have removed the sofa's cushion. In fact, my sofa has no cushion, and I have seen at least a child is sitting. So that is one of the things. If the child is not aware about his body, he will never be aware about his space. So we can't expect a child who is completely disoriented in the environment. He is just running around here and there. He is pumping down. He does not have any idea that, okay, I've got hurt, and he's just doing it. So that means the body awareness is not there. Again, my primary systems are three: tactile, proprioceptive, and vestibular. I'll keep on working on them, make them more strong till the time I'll get a good body awareness. Now, how will we come to know about that the child is having a good body awareness? There are two or three things. When the parents come to me and I just assess them, then I ask them, man, does your child actually scared of heights? You know, the answer I get is no, sir, not at all. He is having no idea about the fear. We are so scared that he can climb anywhere. And down the line, after 1 year of sensory integration therapy, the parent says, you know what, sir, I was just giving him a very high swing. He was very scared. He said, okay, mama, slow down. Or he gave me a reaction where he was feeling scared. So that means, yes, now the child has developed that fear thing. The body awareness has improved. The pain sensation has improved with my sensory input. So that is the most secondary goal of mine, that the child should have a very good body awareness. Then comes the environmental awareness. You know, when I'm talking about the environmental awareness, I'm straight away talking about the imitations. I want, if the sensory integration therapy has given to the kid, three things I always want from the kid. One is a name response. Maybe I'm not expecting he should keep on gazing at me. I'm not expecting that. I'm expecting, if I'm taking the name, he should just give me a 1 second, a blink of an eye, and then he can remove his eyes. Done. That means he's listening to me. That means he's aware about the environment. Second thing is the imitations. Maybe I'm not expecting such a good imitation from the kid, but at least an initiation where he looked at me and he started to copy me. For me, trust me, doctors, let me tell you, imitation is very, 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 very important. Till the time child is not imitating, no matter how much the child is good, he will never ever develop a good speech. I have seen lots of speech therapists just working on the words and words and words, and they are just telling the kid to tell the word 1,000 times. You know what? Obviously, the child will build on that memory. But if the child with a speech without imitation, let me tell you, the communication is never going to be so strong. So for me, environmental awareness is about having that imitations, which is very, very important. Second, whatever is happening around my environment, I should be able to see. So now maybe he's not doing anything. At least he is looking at the room. He is looking at the peoples. That is where the environment awareness comes. So that is the third primary goal of that sensory integration, which I do. Eye contact, definitely we all know that if all three things are going to get achieved, eye contact is definitely going to come. And then comes the emotional responses. So when I'm talking about the emotional responses, I'm talking specifically about the pain sensation. Because trust me, I have seen lots of kids who have a very bad fall. They may cry. You know what? Again, when we assess, we get the answer. When I ask the parents, okay, tell me, does your child has a good pain threshold? Or how, what is about his threshold? They say, okay, no, sir, he's fine, he's fine. I remember he just fell from that stairs and he started crying. No, he's have a very good pain sensation. But when I asked them what was it a very hard hit, they said yes, sir. And for how long did he cry? They said, no, sir, he had a fracture and he was very fine. Maybe after 2 hours, he was very fine. And we were very happy that he's a very strong kid. He is able to have that pain sensation. No, not at all. There are a lot of pains which maybe for which are there for maybe weeks or months. So the child should be aware for such a long period of time. Okay, I got hurt here. Please don't touch me. So these are the things as an occupational therapist, I look for it. So if the pain sensation is not there, I will go for the muscle tone because directly this gives me an indication. If the child is not having a good pain sensation, that means the proprioceptors as well as the interoceptors are not up to the mark. We need to do lot of maybe a muscle tone, muscle strengthening exercises with him. We need to do lot of um, tactile inputs with him, lot of physical exercises where he should be able to bear that weights because weights are very important to have that neuromuscular connection. So these are the basic things which I do, and trust me, these sensory integration therapy goals which I have discussed, this may take at least a year or so. So what happens is the child who has come to me, I started playing with him. I spent 2 months with him only with the play. I did a little bit of a sensory. I worked on the sensory. That doesn't mean that I'm not working on a sensory treatment. But when I talk about an intensive therapy session of a sensory integration therapy, I want a child to be very comfortable with me. So now the second part was where he came to me. We had a sensory sessions. Maybe if the child has a good neuromuscular connections, then this can extend for 6 months or 8 months. And if the child is not having such a strong neuromuscular connection, so this may carry for 2 to 3 years. So it all depends upon how the cognitive part the kid has. So now the sensory integration is therapy is going. Now the parents are coming to me. Now, in fact, the doctors are appreciating and they are saying, now, you know what, I have seen a lot of changes in the kid. Now he has given me that response. And now he's in fact went to the play school where he's sitting, he is having that lunch with the kids, he is sitting in the circle time. That doesn't mean my role has finished. Okay, now his sensory systems are settled. Now, what is my next goal? What should I do next with the kid? So the third thing, um, what I start with is the skills. Now, the child is already 3.5 years old. He does not know how to hold a pencil. He does not know how to catch a ball. He does not know how to scribble, the scissor cutting. Now he needs that skill. He is now his body awareness is fine. His environmental awareness is fine. He's going to the special educators, he's going to the speech therapist. Every therapist is very happy. Now I have to shift my gear. Let me give a sensory diet to the parents and I'll say, okay, fine. This is minimum thing which you have to do with your kid every day. So now this is your duty. Let me move further. So now this time I'll go to the fine motor and gross motor skills. Obviously we know that the grosser skills are primary skills before the finer skills. So obviously the basic skills of catching, throwing, racket hitting, target throwing, this is my basic gross motor skill which I will go. Now you know what, here I will again take 5 minutes in explaining the gross motor skills to you. आप लोगों को लग रहा होगा, okay, fine, it's just a catching now. So either the kids just have to catch the ball, or maybe it's just a throwing thing. Okay, fine. If you are going to teach a child to throw the ball 1,000 times, obviously he will learn. The muscle memory will come into the play. Or maybe if you are teaching the kid racket hitting, he will learn. Obviously, if you're going to practice for 1,000 times, let me tell you, yes, that's where the therapy plays a very important role. Many kids come to me, and I'm talking about a 5-year-old child who is already going for an occupational therapy. The parents come and say, sir, he knows how to catch the ball. I said, fine. I don't believe the parents. The child is not looking at me. He is here and there, and parents are saying, yes, he can catch. You know what type of a catching the child has? Supposedly, if the ball has been given to the kid, he will just hug it with his body And then the parents say, see, sir, he is catching the ball. And we have practiced him a lot. I am sorry, that's not catching for me. The catching for me is that when a child is holding the ball away from the body, that is giving me an idea the child is having an orientation of speed. He has the eye-hand coordination, his visual is stable, his body is stable. That is what catching is all about. See, catching, which is a very simple thing, requires lot of integration. So again, when we are talking about just gross motor skills, we have to go back to our sensory integration therapy, where the child is doing a lot of balance exercises. He was walking on the beam, he was just swinging on the swing, and while swinging on the swing, I gave him a lot of activities to do, which in turn has improved the gross motor skills. Now the child knows the speed, the orientation, the time, the depth, the power I need, the planning I need, all the thing comes. So gross motor are very, very important. Again, one of the most important thing, doctors, which I always believe is if the child, what happens is when the child is catching the ball, you can see, in fact, you have a center where you already have therapists working with you. Just tell them to make the kid do catch and throw. I can assure you, either the child is catching the ball like this, or maybe when he's catching, his head is like this. So this indicates that no, the sensory systems are not integrated. So we need to do lot of those type of complex catching with the kids. So when I'm talking about catching, throwing, racket hitting, or maybe target throwing, I always try to have a good head and visual control. Because if the child is looking somewhere else and he is just throwing the ball, there is no point of saying that the child has developed that skill. So it is a complex thing. Trust me, with autism, we know that visual stabilization is not going to be easy. These are complex goals, but it's as early as you're going to start, we will get a wonderful result. And trust me, we are working a lot with the gross motor skills, and each and every child is showing such a huge improvement in them. So that was all about gross motor skills. Obviously, for gross motor skills, the primary thing we need is a strength in my big muscles, a strength in my postural muscles like quadriceps, hamstrings, my abdominals, my spinal muscles, my shoulder girdles, my pelvic girdles. So while doing the gross motor skills, I can assess a child now. He is not able to stand straight. That means his pelvic girdle muscles are very weak. So that means we need to work now. We will work on muscle strengthening as well as skill. Because supposedly, if my pelvic girdles are not strong and I'm just moving like this, and no matter how much you train the kid with the gross motor skills, you will never get a good result. So in that case, I will go back now here where the neuromuscular technique comes. So when there was my profile was there, and you can see I have written that I work with a neuromuscular developmental techniques. So basically, neuromuscular developmental techniques are those techniques in which we give lot of resistive exercises and postural stability to the kid. It's entirely different from the sensory integration therapy. But now it's time to give lot of strengthening, lot of stability to the child, and then working as well as working on the gross motor skills. The moment we feel now he is having a very good gross motor skills, trust me, rest of the skills are automatically developing. So the child who is already having a good gross motor skills, parents are going to come and tell me, sir, now he is holding the spoon and eating pretty well. Now we are not doing anything. We are not prompting. Now he is brushing, so he is moving his hands so well. Earlier, he just used to do like this. So that is one of the things which we get. So after gross motor, now the child needs to go to school. He's already 5 years of age, 4 or 5. Now going to school means he needs to have that writing, because primary goal in the school is the child should be able to sit, the child should be able to color, he should be able to write, he should not disturb anybody, and he should not make any sort of a misbehaves or running around in the class. So when we talk about the fine motors, again, it seems, okay, हमें writing ही करवानी है ना, हमें तो scissor cutting ही करवानी है ना. No, it's again one of the complex things. Because if the child is not having proper grip and grasp, and if the child is not having the isolations of the finger, trust me, again, keep on working on the fine motors, you will never get a good result. So when I talk about the fine motors, I never start with the handwriting straight away. I will never start away straight away with the coloring. No, let them be aside. Is the child having a good palmar grasp? Is he able to pinch the thing properly? Can he isolate his fingers? Does he have that good hook grasp? Does he knows how to do opponent movements of the thumb? If not, I will keep on working on the shoulder girdle. I'll keep on working on the strengthening of the fingers. I will keep on working on improving the grip and grasp first. So when I talk about the grip and grasp, trust me, you know what? हम लोग as an occupational therapy, the problem is that we keep on working on the skills. We never think about skills are going to develop naturally. There is no point of just keep on making the child write for hours and hours. No, just see why is he not writing. He does not have that pressure in his finger. His wrist is not settled on the table. His shoulder is not weak. It's so weak that he is not able to raise his shoulder while writing. So that's where the biomechanics, that's where the anatomy comes into the play. That's where the occupational therapists actually start working. So again, my primary goal is always is that I should biomechanically make a child independent, and the independence is going to come of its own. There is no need to work so much on the fine motor skills. Work on the basic. Stay to the basic. That's the primary thing. So again, these all grip and grasp, whatever I'm talking about, is a very basic things. Work on it, you will feel. The parents are going to come. The special educators give me a call and say, sir, now he is writing. I don't know what have you done, but now he's holding the pencil and he's doing such a great job. So that's the way of working. That's an ideal way where how the occupational therapist should work. So now I am talking about a child who came to me at the age of 2.5. I do a lot of play. I did sensory integration. I went for the gross motor skills. I came to the fine motor skills. Now he's ready to go to the school, maybe an inclusion or a special school, whatever it is. So now when he entered the school, he has these skills. He is still autism. He is still having autism. He still has that meltdowns. He still have that hyperactivity, because we know these are the traits of autism. But at least he has developed that skill. At least he is aware. At least he is listening. At least he is giving that eye contact. So these are the basic things. So whenever my kids are going to the school, I have a primary goal. This is a criteria where the child should stand. Otherwise, there is no point of putting him to any school. So after the fine motor, now we know that how the fine motor will help. It will help in handwriting, memory, sequencing, auditory, visual, and lot of motor sequencing. Now these are the words which we an occupational therapist use a lot with the hype when we talk about a cognitive part of a child. So this is how we try to do. Now this was a part of a fine motors. Now after the fine motors, the thing which comes is the ADL. ADL means now with these grips and grasp, we tell parents, now you know what, give an hour to your kid. Just take two goals. Maybe if you are taking a goal of toothbrushing, continue that goal at least for a month. Let him brush his teeth 5 times a day. Hardly matters. But take one or two ADL goals. If you are taking a buttoning as a goal, take it for a month or maybe. And if you are struggling somewhere while doing it, come to me. Let me analyze why the child is not doing it. Let me see how I can help you. Let me do the task analysis of that child. So this is the way how we work with the kids. Now with the ADLs, with the fine motors develop, there is a thing which is known as social interaction. So we have a lot of group things which keep on going in our centers. We do a lot of group sessions so that a child should be able to mingle up with the other kids when he's going towards the school. So this is how we progress. So this was just like a case study which we did. I know I was very fast. I'm sorry about it, but because of the time restrictions, and I wanted to express more and more so that I should be able to explain you what exactly the way the occupational therapy should go. So that is the thing. So if you're going to ask me about the conclusion, I am proud to be an occupational therapist because I know as an occupational therapist, I can do wonders with the kid. Trust me, yes, autism is autism, but you know what? Every autistic child, maybe 8 out of 10 autistic child can become independent. It's a very big journey, very long journey for the parents. And they sometimes are very down. Coming to you is just like maybe down the line in the 6 months, they are going to come for that re-evaluation, but they are coming to us every day. So we have to do a lot of counseling with the parents. There are sometimes ups and downs. So, there are lots of things. We are also completely on stress. Maybe that kid was good today, doesn't mean he's going to be good tomorrow. So that's the thing. But thank you everyone for listening to me. Thank you for calling me. And I think I should finish it now. And it's over to you.
Thank you, sir. You're very much on time and very much. The session is very, I think, extremely useful for us. A sort of a new avenue for us. We know what a good OT should look like. Thank you so much. Over to chairpersons for the opening remarks, and then we take the questions in the chat box.
Has Dr. Manjiri joined?
Yes, she's there.
I request her to start.
Yeah, no, wonderful, excellent presentation by Dr. Baka. I think, yeah, for any psychiatrist, even knowing a little bit of this will go a long way. And as you said in the beginning, yeah, even if we are seeing them once in a while for a follow-up, but just to understand how the child is progressing. So important to understand the goals of occupational therapy, help parents and psychoeducate them about home program, and then the comprehensive work that is done with the child. So yes, very, very well conducted, and thank you so much for that work.
Thank you, ma'am.
Thank you, Dr. Baga. It was wonderful. The tips were practical, and a little bit of it, if we learn and if we uh, continue practicing it in our day-to-day practice, we can reinforce the therapeutic applications which they have already learned in you, with you. I was quite amazed by the devotion that you give to the kids, and considering that it's more personalized intervention for every kid. Do you see them individually, each kid which is referred to you, or you see them in group?
No, sir, not in a group because every child is entirely different from the other. So how we start is that, see, the anxiety part is, see, let me tell you, sir, occupational therapy is a manual therapy. Okay. It depends upon the nature of the therapist to therapist. As a human being, there are a lot of people who are aggressive from starting. There are a lot of people who are very soft spoken. So this is the nature, isn't it? So you know what? I don't trust on my junior therapist more because they are very young. They don't have so much of a patience of working with the kid. Kids come to me, first 5, 7 sessions I take, I just make them, and trust me, it just hardly takes 2 to 3 sessions for me. I'm just talking about 1 or 2 months, but hardly takes 2 to 3 sessions, not more than that. So they are very comfortable. The moment they become comfortable, then I introduce my allotted therapist with me. We both work with the kid for 2 to 3 sessions, and then I hand over that kid to my junior therapist. And then every child comes to me at least once in a month to see how the things are going. And I make all the personal individualized goals. And I have hired 2 person who are not therapists, but the duty of there is that they just need to see what are the goals and is my therapist following that goal or not. That's it. So supposedly if I have told my therapist that you have to go for a lot of sensory exploration, so that person is not a professional, but he will go and see and he will check, okay, fine, sir has said that the child has to do sensory exploration, whether the therapist is doing it or not. He just needs to come and inform me. And if he's not doing, then we have a meeting. We have a meeting every month where we try to change the plan if possible. So this is the way I usually work.
So, so great that you follow this biopsychosocial model of treatment that usually is more important in neurodevelopmental disorders. So today I was having a chat with Dr. Rezaul Hamid. He is an eminent psychiatrist based near Guwahati, Assam. He was saying that we have a dearth of occupational therapists in the Northeast, and a lot of physiotherapists are taking up this, OT roles, occupational therapy roles.
Yes, sir.
How do you see that?
Sir, I have no problem with it. Let me tell you why. Because we have just 14 occupational therapy colleges entire country. And look at the population of the autistic kids which has been increased. So there is a huge shortness first. Secondly, if you have gone through my presentation, I've talked a lot about muscle tone, shoulder girdle, pelvic. Don't you think the physiotherapists actually can play a very handy role in it? Absolutely they can. And what is a sensory? There is a very, the difference between the physiotherapy and occupational therapy. I know if there is some occupational therapist in this who is participating, he is going to kill me. But let me be very practical, very practical. The difference between the physiotherapy and occupational therapy is just a functionality. We work, in my presentation, I told you if the child is not able to hold a pencil properly, then I have to go for the biomechanics. So I have a functional goal where my functional goal is the child should be able to write. Maybe the physiotherapist is not having that functional goal. His goal is okay, fine, his fingers are pretty weak. I have to do a little bit of a strengthening exercises with the finger. So the goal may be a little bit different because as an occupational therapist, I have a functional goal. Maybe a physiotherapist does not have that functional goal, doesn't mean that he is having the different perspective with the kid. The only problem with the physiotherapist is the problem is with the OT as well as with the physiotherapist. The OTs believe that we are the best and we have that license of working with the kids in the sensory. No, that's not at all, sir. Sensory can be done by the physiotherapist also. Why do we prepare the parents to do sensory at home? They are not sensory trained, but we train them now. See, your child is having a craving of the some sensory need. You have to give it every 2 hours. So you cannot come to me. Go do that sensory thing. So sensory is one of the things I think where the physios are lagging. But trust me, as a therapist, I'm trying to train lot of therapists from the world so that they should be having that basic understanding of the therapist. And yes, if you're going to ask me, physios can work, but they should use this. Like they have that perception. You know what? The physios also have that perception. We have to deal only orthopedic problem of a child. No, that's not right. You have to deal with the sensory systems also. These all are interconnected. There's a huge difference. I'm very sorry, but around the world, it's not only about our country. I work a lot with the US therapist. You know what answer I get? Okay, fine. You know what? If the child is doing fine motors, it's an occupational therapist duty. We are not going to look towards it. Now, if the child is having a problem with the balance, or maybe he is having a development delay, it's a complete physiotherapist. We don't need a occupational therapist for it. No, not at all. It's throughout the world. I'm telling you, it's you know what? This thing comes from US. They have that insurance wala all panga. Do you getting my point? So they will not get that the insurance. But that's absolutely wrong. Both of them have to work together. I have 6 therapists, physiotherapists working with me, and 8 occupational therapists, and we all are working like a team.
Roshan, I think a wonderful presentation. So you actually did justice to what Aleem sir initiated. That we were imagining that we should have one empty room to bring down the sensory overload during initial interactions. How much involved parents are in your sessions? So this is one of the chat box questions. And do you do parental training or parental management training kind of a thing? And do
Big
they?
time, sir.
Yes.
Big time. See, do you feel in 45 minutes I'll be able to do justice with a child? Not at all. Not at all. How the sessions are made is actually, as I have said you, that I will never tell the parent to go out from the room. Let the primary thing the parent needs to learn is a play. And they can only learn if something is demonstrated in front of them. So that is where they are quiet, but they are looking at me. It's a big learning session for the parents. Acha, mera bacha nahi baith raha. This is how I can make him sit. Okay, why I have bubbles in my house, but I have never used in this way. How attracted he got today with the bubbles. So definitely, sir, parental training is very, very, very important. So the parents have to sit. There are few times when the child is settled. I have given a goal to the parents. See, these are the things, just achieve it in a month. So if the parent has got that goals, now you can sit outside. Let me take the session of that kid, or let my therapist take a session of my kid, because you don't have such a big commercial OT room at your home. So let him do all that explorations in my OT center. But the things which you have at your home, you can have a gym ball, you can have a therapies, you can have lots of small stuffs. So that goal has been given to the parent. And the big goals where you need a very commercial equipment, that is always kept in my center.
Uh, because see, we deal with primarily with behavioral issues. The parents will come to us. How you handle them, or tailor made your sessions to handle aggression or emotional outbursts in these in the kids.
Sir, there are two, three things. First, again, I'll come back again and again. I will come back to the word anxiety, and trust me, this is a primary thing. This is a primary thing which is giving the behaviors to kids. Secondly, sir, every behavior is actually has a reason. Okay, every behavior has a reason. My center is in a basement. Okay, trust me, there are a lot of kids who are scared of that exhaust fan, and the moment they enter my clinic, they are howling like that, and parents are not able to understand that thing. So parents say, sir, this happens always, this happens whenever we go somewhere outside, or when this happens very commonly if he will go somewhere in others bathroom, because he does not want to go to somebody else bathroom, he will come back and he will do washroom in his own bathroom. That is a thing. Every behavior has some reason for it, and trust me, it's very difficult question. You need to spend time with a child. Maybe there is some triggering thing, maybe the anxiety is playing a part, maybe we are going against the kid, he does not want to do and we are making him to do. Maybe there is a thing that we are not using a proper reinforcers. They have that reinforcers. Maybe that stimmy toy is a reinforcer then. So let me use it in a way where I can reduce that behavior. So there can be n number of reasons of behaviors. But yes, sir, trust me, there are only 5 or 6 strategies as a therapist we have to apply, and 8 out of 10 kids, that's successful. That's no matter if he's having a sensory overload, if he's having meltdowns or whatever, it works. It works with the kids.
One specific scenario, Dr. Sakshi has asked the chat box that child has global development delay with autistic traits. He is unable to jump well, although he can bounce on the gym ball. How to commit a timeline to the parent? Current age of the child is 3.5 years.
Can you repeat it again, sir? I just want to listen it again.
But the child is that there is child has a global development delay with autistic traits. He's
Hmm.
unable to jump well,
Hmm.
although can bounce on the gym ball.
Hmm.
To commit a timeline to the parent for subsequent. Uh,
First of all, the goal is absolutely wrong. Remember, we are attaching two things: developmental delay plus autism. So, if there is a developmental delay, that means the muscle tone of a child is very weak. How can you expect a child having such a low muscle tone will jump independently on a trampoline? Because that requires a very strong vestibular system, that requires a very strong extensor tone. So practically, if I feel the child is not able to stand at one place, or suppose that if he's lifting his one leg in the air, he is getting horrified, I will straight away say to the parents, I am sorry, you can have any goals in your mind, but practically it's not possible. The condition of the child is that he is not able to lift his one leg, and you are expecting from the therapist that he should give that bouncing and jumping. No, not at all. I will straight away explain the things to the parents. Let me see how, because see, sir, supposedly if we are saying, okay, we will teach the jumping, we will teach the jumping, and every time we are trying that thing, there is no point of doing those things. So that is one of the things. It needs a very depth analysis of the kid.
We take some questions
I,
from.
I think there are many questions in the chat box. One is
Yeah.
there regarding parental training, and suppose everyone does not have access to OT. So, do you have any modules, any ideas, what we can suggest parents they do in their home, they do at their home, so that your load is taken off a bit.
So it's very a difficult thing, because I'm just going around the country and I can see actually the occupational therapists have just one mindset: sensory. That's it. The therapists are actually not playing with the kids. The therapists are not doing like a justice by giving a good home plan to them. So this is a big struggle. I don't know. I really don't have an answer for it. what I was trying to do is that I was trying to have that parental workshops somewhere. And I have conducted, I know, like Dr. Kshitij Srivastav in Allahabad, we conducted a very successful workshop only for the parents. It was just like Dr. Kshitij told me, you know what, forget about the big terms. I don't want to hear those terms. I want the basic things. Let the parents understand those things. And I hope that it was very useful for the parents, very, very useful for the parents. So this is the only thing, sir, what we can do is that we can have a lot of workshops so that the parent should be able to understand the kids. And then the second part is the treatment protocol, but it's a very hard thing. So
Okay. Questions from the chat box, please.
So there is a question. I think she's also raised her hand. Divyasha, she's asked. My question is how to manage child. Sorry, ma'am, we will not be able to unmute you. We'll read your question. My question is how to manage child of late age, like 10 to 11 years, with so much sensory issues where parents are not financially strong to afford regular therapy. And in India, occupational therapy for kids is not available in government hospital.
So
Yes.
it's more of a resource-based question.
So you know what? There are basic techniques which every occupational therapist is using. Like I know you will be also aware, like the brushing techniques, the deep pressures, and the bouncing techniques. I know again the problem is that a child is too old, like he is 8 or 9 or 10. I think that's what was the age is. So keep on working on that basic techniques. Don't stop that basic thing with the kid first. Secondly, do lot of relaxation therapies with him. Like a deep pressure is a very good. If he's a very hyperactive kid, trust me, maybe wrapping him and giving that deep pressure will actually relax him. Third is always keep on doing the basic heavy exercises. Maybe there are a lot of animal walks. There are lot of heavy things like just a simple activity, lifting anything heavy and just climbing up the stairs up and down 5 to 10 times.
Can you
You,
elaborate pressure techniques?
sorry, ma'am. Sorry, sir.
Deep pressure techniques, can you elaborate on
Yeah,
that?
actually, deep pressure techniques is basically what, again, I have also developed my protocol. So what I do is basically I have 4 things in the deep pressure technique. One is that having a very soft, gentle, deep pressures on the body. Like it's just like a massage. We do it with a very good moisturizers. That is the first thing, so that the child should get relaxed. The moment he's relaxed with my touch and he's allowing me to do a massage in his hand, I will go for the brushing techniques. Now we have that Velvager's brush or therapeutic brush, which is a white color, which is actually made for that autistic kids, the sensitive kids. And I use that soft brush very deeply around the skin. So that's the second step I follow. First is the massage. Second is the deep brushing. Third, I go for a spinal massage. Trust me, that spinal massage, the massage around the vertebrae and in the back, a very deep massage relaxes a kid a lot. So doing a lot of a deep massage in the back and then going for a deep brushing in the back and then going for that pressures, maybe with a gym ball, maybe with the bolsters. And it will be great if a child accepts that wrapping in the bed sheet. It will be great. So that will actually organize, it will relax the kid. So I have 4 or 5 strategies, basic strategies, which I have in a deep pressure technique.
I hope he's answered your question.
Yes.
So also some people are asking, because in metros we have OT services available. What about, in smaller towns and rural areas? Do you have any online resources where people can, or parents can read, or doctors can read and help the clients?
Yes, sir. Sir, you know what? I have my own YouTube channel, and trust me, it's not about the publicity. I would request each and every parent, please go and watch the sensory videos and all my videos. Trust me, they, without any workshops, without anything, they will come to know about their kids. There are lots of parents around the world. You will be surprised, the parents who don't even understand Hindi, they are listening to the things, and I am getting lots of, unfortunately I don't have so much of time, but around the world they are asking the question and they have actually complimented me. Thank you, sir, I am able to understand my kid. So
So can
this
you
is
can you post the YouTube channel link in the chat box so you can share also?
yeah, definitely, I'll do it. They can just type.
Not only parents.
Anyone. Hey, for everyone. That's it.
Yes, sir. I think for the doctors also, it's very important to understand the occupational therapy. So that is the thing.
Yes. So also,
Again,
somebody's asking, is there any protocol the patient comes to us, because we don't know any protocol for ASD patients, how much therapy, how many, because some patients say, Doctor Saab, and they say, Doctor Saab, 3 years ho gaye therapy, nothing has happened, we are spending so much of money, it's a waste of money, should we stop the therapy? We keep hearing this.
Yes.
Can you put some realistic expectations of, again, how much therapy is required, maybe mild, moderate, severe in case we say autism, and how long and what can we see, so that we can at least reassure them, please wait for some more time, please don't discontinue and all that stuff.
You know, sir, I'm going to put it in the other way. Now the parents comes to us कहते हैं कि सर हमें डॉक्टर के पास नहीं जाना. We don't want to give medication. If we'll go to doctor, they will prescribe a medication.
Right.
You know what? How I work is, sir, and you know there are lots of very good doctors. I just have that they are just like a father figure or mother figure to me. And like मुझे मेरे पास फोन आता है and they say me, okay, Roshan, 3 महीने हो गए तुम्हारे पास भेजे हो, इस बच्चे में इंप्रूवमेंट नहीं आ रहा, क्या चक्कर है ये? They have, we have just this type of a thing. So you know what I do is basically I always say कि have an intensive occupational therapy just for 3 months. And sir, trust me, अगर मुझे लगता है I am not doing the justice, I straight away say, see, your child needs psychiatrist, he needs medication, you have to go there. And then that's where, and sometimes what happens is कि doctors give me a call, रोशन एक बच्चा रेफर कर रहा हूँ, 3 महीने तुम्हें दे रहा हूँ, अभी मैंने सिर्फ सप्लीमेंट्स देके छोड़ा हुआ है इसको, 3 महीने है, they need to come back me and you are going to decide whether we should put him into medications or not. So it's both the ways, the things are going both the ways. But मैं कोई नया बच्चा अगर आएगा, I will try 3 rigorous. So 3 months means at least 20 sessions in a week, in a month. So at least 60 sessions. And then we and doctors, we both decide how we have to move further. So it's a very joint thing, sir, trust me. I don't even think working without the psychiatrist in my profession or maybe the neurologist in my profession. And the same is with, like in Delhi it is. With me it is, like the doctors are very comfortable with me.
Right.
Roshan, can you tell us some of the basic techniques that as you just explained, that hugging and wrapping in the bed sheet. So can you explain what actually is done in such basic techniques? Most basic techniques, regular techniques, what you do?
Yes, sir. See, sir, as I have told you, there are 3 basic sensory systems which we have to take care of. Okay. So when we basically talk about sensory integration therapy, so what happens is sensory integration therapy is more where the child has to participate in the activities. So that is a second step. Before going for the sensory integration therapy, it's very important to reduce the sensitivity of a child. Because suppose that if the child is scared of the swings, then how will we able to integrate in the sensory systems? We can't.
So how do you reduce sensitivity then?
Sir, what we do is, if the child is very scared and is having very sensitive vestibular system, I will not straight away put him into the ball. I will just hug him. I'll take a round with him. I will sit in a swing, maybe in a round swing. We have a very big swing, and I tightly hug a child because already he has built a trust with me, and I am going to move on the swing. And supposedly now the child is comfortable. Now there will be a time, maybe after 2, 4, 5 sessions, the child will become comfortable and we'll start with slow and rhythmic movement with the child. Now I'm talking about one case, which is hypersensitive. Supposedly, if the child is extremely hyper, he just wants to come and run in the swing and bounce in the ball. In that case, primary thing is reduce or remove all the stimulations from the room. That is a primary thing, trust me. In the hyperactive kid is remove the overstimulations from the room. Trust me, 20% of the job will be done. If they will not find the trampolines, if they are not going to find the balls, you will see they are automatically they are going to come to you and they are going to listen to you. So these are the primary things basically, which again dependent upon the child to child. But the basic things what we do is to reduce the sensitivities. If the child who is having a very high vestibular system, I'll hug him, I'll give a very rhythmic movement so that now your vestibular system should get settled down. The liquid should really settle down. And if the child is very scared of that movement, again, I will try to move him in a very unrhythmic way, so that your system should get ready about it. So again, sir, depending upon case to case, the strategies are entirely different.
Yeah, the next level then.
And then next level is that now it's your turn, you go for it. Now the passive therapy is gone. Passive means that now I have been the initiators. Now I'm not going to get any, now I'm not going to be there. You need to participate now. You are comfortable with the swing, you climb up the swing. You get down from the swing. Now you are comfortable with your sensory systems. Now you need to work with the dirty hands. Don't say that you are going to remove. So if your hands are dirty, you have to do writing today with that dirty hands. You have to walk with that dirty legs. If you supposedly, if you need lot of pressures, you have a hand gripper. Use it. Use that hand gripper for you. Let your sensory system. You need to settle down. So that becomes an active participation of the child. And then we make one obstacle where the child needs to balance. Then he needs to get down, crawl the tunnel, stand up, have 3 jumps, go there, walk on that mat. Then that circuit, the sensory circuit starts. So first is to reduce that sensitivity.
If a child is not cooperating in this,
That's why he's coming to us, na, sir. That is why he's coming to us. This is a challenge which the occupational therapist has. सर कोई भी बच्चा आता है, कोई भी नहीं वर्क, ऑटिस्टिक में कौन वर्क करना चाहता है? कोई भी नहीं वर्क करना चाहता सर. No child is going to be a cooperative child. It's me. How much I can take out from that kid.
okay. So this was regarding vestibular system you are resetting.
The tactile and proprioceptive, all 3 systems.
Okay.
A couple
Okay.
of
And what are the yeah.
Sorry.
We shall carry on.
Yeah, so there are a couple of questions on how do you manage when you have child has ADHD also along with autism, hyperactivity, how do you manage, how do you balance? There are 3 questions on the same similar stuff.
Well, actually, I believe, see, I don't know. Maybe I'm wrong, sir. I'm not so experienced. Autism and ADHD coming both together is a little bit of a thing which I'm not able to understand, to be very frank. Because if ADHD and autism are together, I think autism is having more upper hand than
No, that is true. No, what is, it's not like that. In terms of therapy, if the child is hyperactive, autistic child, but also hyperactive. And so that happens, that combination happens. How do you manage that hyperactivity in therapy? That is the question.
So by settling the system, sensory system, sir.
Okay.
That's the primary thing. Because when we talk about the hyperactivity, again, sir, the culprits are the vestibular systems and the proprioceptive systems. So imagine if the child is too hyper. So that means he's not having that awareness of that environment. Let me put a weight cuff on your hands. Let me put a weight cuff on your legs so that your body should now be able to integrate with your brain. So that is a proprioception. Now you have settled. Let's go for a rhythmic bouncing now, or maybe a rhythmic swing. Switch off the light, have a light music, sit on a swing and just relax for 10 to 15 minutes. So where I am just settling that vestibular system. So maybe putting a weights, maybe a weighted jacket, weight cuff to reduce that running around, and then making him sit on the vestibular system so that both the systems, the proprioceptive and the vestibular, can go together. Now,
So
yes.
please continue.
But it's not always that the things are going to work for me, because there are lots of cases where the child is not ready to have any type of a sensory inputs. And so what we do, we have lot of sensory toys, lot of fine motors, lot of attractive things with it. Fine. My first is to give you proprioceptive vestibular. That's not working for me. Let me have attractive toys for you. If that's not working, what do you want? What is the biggest reinforcer you have? Let me use that reinforcer, and we are going to talk with that reinforcer. If that is also not working, you know what? Then the thing is that maybe there is a time where I have to say enough is enough. Now you have to say, now I can't handle. I have given you a lot of opportunities. Maybe that firm voice can also make him settle down. So again, it depends upon the strategies and the issue the kid is.
I think we can start closing. We're just almost done with.
How do you screen whether a child is hyperactive or hyperactive?
Sir, again, it completely depends upon how he is responding. Now, with my experience, let me tell you, if the child is having too much of anxiety, the vestibular system is definitely in the hypo side. He is scared of the heights, first of all. I can assure you that thing. Obviously, one of the reasons why I'm saying is that when the child who is scared of the space will always try to be confined because he's scared of that space. So when a child who is confined will always be an anxious child whenever you are going to take him to the big environment. So one of the things what I feel is anxiety is there, then that means the vestibular system is completely distorted. Secondly, if the child is coming to me and the parents are saying, sir, ये 3 साल का हो गया अभी तक ग्लास नहीं पकड़ता, सर ये 3 साल का हो गया अभी तक पेंसिल नहीं पकड़ा, that means the tactile system is not working. He is having a sensitivity in the tips. And doctors, you should do something. Maybe down the line, just call when the kids are coming, just try to press their fingertips a little bit and see how the child is responding. Trust me, out of 10, 5 kids, the moment you are just going to press it, they're just going to give this response. So that will give me an idea. Fine, he is having so much of high pain thing that how will he hold the pencil? How will he hold the spoon with a tight grip? So again, sir, it's completely a clinical observation I do,
So
to which
hyposensitive.
I come to know whether the sensory system is in a hyper or in a hypo side.
So sensitive to pain can be a direct marker to say whether the
Of
child.
tactile defensiveness.
Okay. So one of the domains of sensory.
Yes, sir. Because if I have a too much of sensitivity in my hands, I will not hold anything now. And the moment if I'm not holding anything, my fine motors are not going to develop. If my fine motors are not developing, how is my cerebellum is going to develop? Because for cerebellum development, my fingers are playing the major role.
Okay, suppose now a child or becomes an adult and then he's landing up to you. So in rather persons who are adult or across 18, 20 years, so what can be done then?
Sir, I will never stop a sensory treatment with them. I will never ever stop the sensory treatment. I will keep on working, first of all, because sensory settlement can happen anytime. Secondly, it depends upon if the adult is not having a basic skills also, then it comes more into the vocational training where I will not go for much for the sensory treatment. I will see why he is not doing, maybe biomechanically, muscle strength is not good, the coordination is not good, then my goal will be entirely practical and functional. Fine. Now that means we need to do a lot of strengthening. Forget about this jula, forget about this weight cuffs, forget about this weighted jackets. This is not going to work for us. The practical thing is that he should be able to maintain that posture. He should be able to walk with that weight. He should be able to manipulate the fingers. He should be able to practically do all the things. And then I will do a task analysis. If he is not doing these things, why he is not doing it, I'll go more for a neuromuscular developmental technique treatments rather than going for the sensory treatments. So no jhula, no weight cuff, nothing like that for an adult.
I think a basic question in that sense that like level 2, level 3 autism, how many of them actually then you are able to push them to level 1 that is functional? Your experience.
Sir, again, I would say it will be very hard, but my goal is not to put them into the level 1 or level 3 to level 2 or level 2 to level 1. My goal is to make them independent. No matter if I have to change the environment, if I have to do the modification in the environment, if I have to do the modification in a spoon, I have to do a modification in a pencil. But let him be in a level 3, let him be in a level 2, but he should be independent. Functionally he should be able to do the things. That's the primary goal. And so you know what, practically it's not me who can bring them to the level 2 or level 3, it's their cognitive development, to be very frank. If they have that cognitive thing, they obviously are going to come to level 2 and level 1, a high level of autism, they can go for it. It completely depends when we expose the child to the therapies.
I think so. There are also a lot of questions regarding the manuals and all. Alim sir, we can request Roshan to give us more detailed manuals, each and specific domains in subsequent sessions.
Yeah. Any resources that you'd like to share it with us so we can share it on our group. People can contact you.
I'll just try. I'll just try to put it in the group. So I think we all are in the group, so that can really help you. But sir, to be very frank, what I have discussed today, it's all my experience. Trust me. I have worked like anything with the kids.
We wanted that only. We
So
wanted
I
that only.
haven't penned down it
Yeah.
yet. So
Okay.
but there are lots of referral books I'm using, so
No
I
issues,
can
no
just
issues.
put those things. So that will be great help. Like Jean Iris is one of the mothers of sensory integration development around the world. So I read a lot of her books. I can just try to put those resources.
Whatever you think. I think we should now start to wind up. 9:26 already.
Yes. Yes. But at least, so thank you, Roshan. I checked you're near me. I'm in Pitampura and you're in Rajouri order.
Oh sir, मुझे ऐसे लग रहा है I've seen you many times. I
I'll
don't
try
know
and
where,
visit you
but
sometime. This is good.
you're a very familiar face for me. But
Yeah.
okay, thank you, sir.
Thank you. Any remarks on the chairperson? I think Bikramji is
Not
also
much.
only there.
It was wonderful, sir. Dr. Roshan. What I learned today are very easy and practical tips. So three things which I could understand from your talk, that the therapy should involve very playful and enjoyable practices for the children. The motivation of the parents should be kept so that they practice it and there is a generalization in the setting. And the third is that it should be a collaborative approach where, the psychiatrist and everyone else involved in the child care, they all contribute. Thank you so much, sir. We learned a lot.
Thank you, sir. The pleasure is
Thank
mine, sir.
you. Thank you. Tufan sir, then over to Amrit.
Thank you, Dr. Baga. It was an enlightening experience to listen to you. I have got two simple observations or queries, whatever you may tell. Do you face carer burnout?
Sorry, sir.
Carers burnout.
Caregivers burnout.
Okay. I didn't get the question, sir. Can you please repeat it, sir?
You face situations when parents give up and tell we cannot go further. It is not.
Yes, sir. A lot, sir. A lot. So you know what, sir? I then at that moment, what I do is I tell parents, come sit with me. I am taking the kids session. See the small changes I'm going to show you today in my session. You have to make the parent sit with you and tell him, see, the thing he has done, he was not doing previously. Look, it's a very small thing which he has done, but look at the amount of planning he required to do such a small thing. So we have to boost her. This is one of the major thing as an occupational therapist I do. We have to boost. We have to make the parents sit with us, work with your child. Look your child when he came, and we used to show them the videos also. We have a lot of video recordings with us. Look what he was, now what he is. So then we have to counsel. Definitely we have to counsel a lot.
Okay, thank you for being optimistic. And still, Utti has to develop all over the country. It's not available to many. It's not in many places. There are not sufficient occupational therapists. And it involves money, which is not with many patients. Anyway, it has to develop. Thank you very much.
Thank you,
Be the
sir.
best touch bearer.
Thank you very much.
Over to
Amit,
Amit.
over to you.
Sir, I
Wind up
just
the
wanted to ask one or two things. How much do you charge per session?
How much I charge per session? Oh my God. You're talking about offline or online?
Offline.
That's a difficult question, sir. So my
No,
actually
because you told that somebody needs 60 sessions. So
Yeah. So
in
what I
three
basically do,
months.
sir, my session charges varies from 1,700 to 2,000 per session for half an hour to 45 minutes. And then my junior session is about 1,200 per session for 45 minutes. And about the assessment is a little bit higher because it requires at least 2 to 3 sessions. So the complete assessment charges is about 8,000 to 10,000.
Thank you.
But sir, it's all about forget about the money. Forget about
No, money is important, sir. Money is important. Money is very important. It is when you have 60 sessions, you need to. It's not about 5 sessions.
Absolutely, sir. That's what I'm saying. That's what I'm saying. I know.
But if you can give improvement, if you can give the changes, I think it's worth it.
Yes,
Second very important thing is there was a very good question. People talked about a autistic child presenting with ADHD. Okay. And if you look at a place like India, it is around 20 to 25%. There will be comorbidity. And if you can't manage the ADHD, none of your therapies work. So one of the primary things when you have somebody with ADHD and autism is send him to a psychiatrist, get on some medications. I see a lot of
I'm just telling you, I've seen a lot of people who are not responding to whatever sunset, whatever things you are doing because the ADHD is not controlled.
Absolutely, sir.
So first,
Completely.
I think the ADHD needs to be controlled, and there is no better and easier way than to send him to a psychiatrist, get him on some stimulants, and get him on track, and then you give therapies. The improvement is significant. That's what I have seen. Because there is a reluctance by many of the occupational therapists to send patients for medications. Parents themselves are reluctant for medications. A lot of resistance, a lot of denial in terms of they requiring medicines. We see a lot of people coming 5 years, 7 years down the line who have spent a lot of money. And these occupational therapy units are not there in the peripheral centers, they're in cities. So many of the families have to come to a place like Delhi, a place like maybe Dehradun, Calcutta, stay there for 2 years, 3 years, living everything, and trying to take care of and if you're not taking to take care of the ADHD, there are a lot of issues. It's just like digging in a blind hole. So I think that's one aspect it needs to be taken care of. All in all, it was a wonderful session. Thank you, Dr. Vaga. We will again call you and we'll see your videos. We'll learn a lot and we'll get back to you again and again. Thank you, Bikram. Thank you, Manjari. I think she has just left. And thank you, Dr. Tufan, and the three pillars, Dr. Shobit, Dr. Vishal, and my enemy, Alim Siddiqui. Thank you so much. Good night. Have a great time. We had a lot of people today, more than 170, 180, in spite of Alim, being there. So thank you. Good night. See you again next week. Bye-bye.
Good night.
Thank you.
Good
Thank
night,
you. Good
everybody.
night. Good night. Good night, everyone.
Thank
Ending
you.
the meeting now. Ending the meeting. Thank you. Thank you, Bhagat. Thank you.
Thank you.